from across Asia Pacific. I can see we have got about 210 and the numbers are going up. Raul, you have got a fantastic audience set up for this evening for your topic, the multi-layering technique for lower face rejuvenation. You're no stranger to this part of the world, Raul.
Yeah, no, I'm very happy to be here today, and it's been amazing because I got to visit the region a few years ago, but then over this last year and a half during all these lockdowns, it's been an absolute pleasure to be able to interact with colleagues and really to share and learn from them as well in terms of the technique and what's important for them. So it's an absolute pleasure to be here.
Fantastic, Raul. For those people who have not had an opportunity to meet with you so far or interact with you either in via webinar or a masterclass or the conversations, let's quickly do a brief intro. Melanie, if I could have the next slide, please. Yes, my name is Chris Sai. I'm very fortunate to lead this fantastic dioxin team as the head of Asia Pacific region, but tonight is not about me. Next slide, please. Fantastic. So, ladies and gentlemen, Dr. Raul Chetto, ENT surgeon from UK, has more than a decade of facial aesthetics experience. He is an award-winning international speaker and trainer. We're very fortunate to have him speak for us for Dioxin. Very busy right now. He's doing a number of events across the globe, and I mean it across the globe, including United States, where Raul has spent significant time training up the American aesthetic physicians. He holds a position as a professor of facial aesthetics for the master's course at Italian University in Napoli. Dr. Raul Chetto is also finding time to do research and publish. Him and another colleague of his, Dr. Lee Walker, who I'm sure you're familiar, have come up with a couple of books, and they do they're very active in research as well as in a number of publications. So he's an all-rounder, if you will, Dr. Raul Chetto. I'm sure he's got some very practical concepts that are relatable to you that you can put into practice with regards to lower face rejuvenation. And he's going to tease out the concept of multi-layering technique if you haven't heard about this or if you haven't used it already. We have now, Raul, about 275 people who are waiting to hear from you. I'm just going to remind everybody you have a Q&A box and a chat box. Please do take time to drop in your questions at any time. We will have Jacqueline Ng, who's our medical education manager, come up right at the end. Raul is going to take about 70 minutes with this presentation, and then Jack and Raul will do a nice dialogue of all your questions, and we'll make every effort possible to answer each and every question of yours. So without any further ado, Raul, I'm going to pass on the screen right to you. Yes, we can see it. Take us away, Raul, please.
Thank you very much, Krish, and thank you to my colleagues from the Asia Pacific region for joining us today. The main aim of my presentation really is having a chat here with the team and really think about my own journey with these products. I'm sure we have colleagues here who are familiar with the range, so they will be familiar with this multi-layering technique. But there's also a group of you, probably very similar to me, just over 5 years ago when these products were introduced to me and the concept of multi-layering technique, that you're not quite there yet, and we're kind of in the process of understanding the why we place product deep and superficial, and also the importance of the rheology and the differences between these tissues. So really my aim is to make you all more comfortable with the multi-layering technique and with the applied rheology, but also to my colleagues that are familiar with the products, just to give you a little bit of an update on the anatomy and the aging process that really, I think, reinforces our approach to treating the aging process. And to begin, so one of the things that we'll discuss here is what our approach to medicine and to injectables is, which is really an evidence-based approach, which we call the Dioxin approach. Then we'll discuss the anatomy and the aging process, which will really help cement to us those changes that occur both in the deep and the more superficial planes, and how we can best address them to achieve better outcomes for our patients, more natural outcomes for them, but also more efficient outcomes because we can achieve more with less. Then we'll talk about the differences between gender in the lower face. And I feel this is something very important now, especially as these treatments have become more and more popular. We're beginning to see a lot of these lower face treatments masculinize our female patients, or really not enhance their own gender features. So we'll touch on that and those differences and how to avoid these kind of outcomes. Then we'll discuss product selection, my rationale behind product selection, which again is very evidence-based and driven. And then we'll go through some video examples of applying these concepts. So hopefully you'll find this valuable, and then we'll have time to ask and interact with each other. So first we begin with the teoxin approach. And what this really is our evidence-based approach to facial anatomy and aging, because we know that we're usually treating the aging process. So it's important that we familiarize ourselves with the anatomy, especially with the anatomy pertinent to injectors, which is in layers, a little bit different to the surgical anatomy that we learn for clinical and hospital medicine. And then how to assess and apply this to our patients. And based on that, then we are going to choose a technique that will be effective and safer for our own patients based on these principles. But also, we're going to assess our patients, remember, not just in 3D, but also in dynamic expression, because the face is incredibly dynamic. So it's important that we are constantly, even throughout our injections, assessing our patients, getting them to sit up, animate, so that we can see how our treatments are responding to these highly dynamic compartments of the face, and in order for us to avoid creating unnatural outcomes. And then we'll go through our rationale behind product selection. And this is something that's quite important, because we know that these different tissues, these different areas of the face, will have different biomechanical properties. So it's important that we marry the rheology to these different layers. And together, this is what we call the fourth dimension in facial aesthetics, is that we're moving from 3D static assessment to 4D in terms of assessing our patients in animation, in expression. And like everything, we begin with the anatomy of the lower face. And in the lower face, similar to the mid face, we have the deep compartments, which are static. So this will be bone and deep fat. And then we have our third layer, which will be SMAS or muscle. And above there, we have the superficial fat and the skin. So everything above the muscle or the SMAS will be mobile and subject to movement as we express. But then also, we have to understand the differences between the static deep compartments and the superficial ones. Well, there are differences. Even though the deep fat there is attached to the bone, it has very different biomechanical properties to the superficial fat. And the reason for this is because the superficial fat is constantly being sandwiched in and compressed in between the muscle and the skin. So it needs to have different properties in order to withstand these forces that are being applied to it. And we know from more recent literature that there are biomechanical differences between these two structures. The superficial fat is comprised of these small adipocytes that are interconnected with fibrous tissue that connects them to the dermis. But most importantly, it's a highly stable structure with very high elastic properties, whereas the deep fat is the deep fat that's attached to the bone. It's comprised of these large adipocytes that have very low structural stability and no viscoelastic properties. So it's important that we familiarize ourselves with the differences between the fat that we have in the face, because this will really guide us in terms of our applied rheology, as we will see later on in the presentation. Now, I'm an advocate really of cannula used when injecting superficially. This is purely because of the access to larger surface area. But if we explore the anatomy, especially anatomy in layers here, we have the anterior midface, lower face, which will be the area of the chin, which is incredibly dynamic there. We have 5 layers there, and we have that very complex musculature there, and these 18 muscles that are interconnected with the orbicularis oris muscle. So we have a very highly dynamic area there, as you can see. And the aging process, which we don't see in this young model, results in that dynamic discord because of the atrophy of the superficial fat there. So we begin to see these movements from the DAO and earlier from the mentalis become more obvious and more apparent in this area as we age. And this dynamic discord is something that we can treat with restoration of volume, but it's important that we understand what layers will lose volume in order to achieve good outcomes. What separates the anterior lower face with the posterior lower face is really the mandibular ligament, which is a true ligament there that has a cutaneous attachment in the oral commissure and a deep attachment inferiorly. And medially there, around that area, we have the depressor anguli oris. And also, the marionette fold is due to the hypertrophy of the fat lateral to the mandibular ligament and also the atrophy of the fat medial to it. And if we explore the jawline, so the jawline is what we call the static lower face. So here we've removed there the skin and we see the platysma muscle there. And we see that facial pedicle there. And more medially there, we will see the mandibular ligament. And we're able to see how there's a different distribution in layers there from the mandibular ligament laterally and medially. There we see the muscle and below the platysma, but also above there, we will see the parotid gland in the jawline. And in terms of vascular risk, we know that they are deep here, entering in the bony layer. And then as the facial artery ascends, it's just under the muscle, and then it goes into the chin, and then will be in layer 3, and then will become more superficially as the artery continues to ascend, and it will give off some of its branches there. So it's just a brief overview of the anatomy, but let's now explore it with more detail. The chin, we have 5 layers here. So we will have bone, and then deep fat that's attached to the bone. Then we will have the mentalis muscle, then the superficial fat and the skin. And it's really the superficial fat here that is responsible for that contour of the chin. So we will go into a little bit later the aging process of this area and how it affects the chin. And here we see a dissection here, a cross-section where we've removed the skin there and the superficial fat. And we can see here that we see that branch, that mental branch there of the facial artery, how it's in our layer 3. But we also see those muscles there intercollecting. We see the mentalis muscle, we see the DAO, but we also see the depressor labia inferioris there as well. And we begin to have a clearer idea of this highly dynamic area and these muscles that are interconnecting there and attached to the orbicularis oris muscle, making it a highly, highly dynamic area. Here we see the boundaries there of the mandibular ligament and the DAO muscle. So we see the superior boundary there, cutaneous attachment to the DAO, and inferior will be determined by the mandibular ligament itself, which is a true ligament there in the lower face. So it's one of the 2 true osteocutaneous ligaments that we have there, which we will explore in more detail shortly. And if we go into just a brief illustration of this dynamic area here of the lower face, which is the chin, we see these muscles, the depressor labia inferioris, the mentalis muscle, the DAO muscle, which is a triangular shape and it extends far more laterally to the mandibular ligament. And then we see these vascular structures that we were discussing earlier. We see how that facial artery is under the platysma, and then it's under the DAO, so it's in our layer 3 when it goes into the chin. But then we also have those branches of the facial artery that go into the chin, and they create the ascending mental artery. What is very important there of that ascending mental artery is that it starts off deep, but then it's superficial, and it's around 3 millimeters from the midline there of the chin, and its depth, as you know, we know it with multiple of these arteries, will be variable. So we can see variations there in the depth of this artery, and it's very close also to the midline, which is the area that we tend to enhance when we're doing rejuvenation or enhancement treatment. Now, if we move on to the lateral lower face, so to the jawline here, we're able to see a couple of things here. And we see how if we remove the skin here and the superficial fat there in the jawline, we see the platysmal muscle. Medially there, we will see the mandibular ligament there that is just in front of the DAO muscle. And then behind it, we see the facial pedicle, and the anterior limit there of the masseter muscle here. Now, why is this important? Because we've discussed really the 5 layers of the chin, so the anterior part of the lower face. But if we look at the layers here in the gonial angle and the jawline, we have a different distribution here. And the different distribution is because we have, number one, in the deep layer, we have the bone, and then we have the muscle that is attached to the bone, which is the masseter. And this is very important because similar to our upper temporal compartment, any deep injection that we do on the bone, on the gonial angle, will be an intramuscular injection. So we need to think about the maximizing our injectable outcomes, and also in giving our patients the most benefit from these volumization treatments. And also, we need to know that because the muscle is strongly attached there to the bone, any deep injection that we do there, our needle will be touching the bone, but the product will be placed on the structure that is attached to the bone, which is the masseter muscle. But also, we will see another variation here, which is the fact that we have the parotid gland in this area. And we have the parotid gland here in between the masseter and the platysma. And at the gonial angle, you'll find the inferior border of the parotid. But when we're treating the jawline itself, we will see the posterior jawline to enhance that those angles. We see that we will have the parotid gland there. Now, we're seeing complications here from injections into the parotid gland as the lateral lymphatics of the infraorbital region drain to the parotid gland. So we're seeing patients that are having HA injected into the parotid gland, either because of a large bolus here into the masseter, or because of not placing product here superficially in that subdermal plane. And patients return after a few weeks with malar edema because of that disruption of lymphatics. So this is why we need to be aware of the layers that we're treating. And this is how we view the anatomy as injectors. And also how there are differences even within the same region as it's in the lower face. So we've discussed 5 layers, which is a traditional arrangement of layers in the chin. However, a very different arrangement of layers in the gonial angle and in the posterior part of the jawline. In terms of the vascular risks here, so we discussed earlier, we have our facial artery here emerging deep here anterior to the masseter muscle. And then as it ascends, it will become more superficial. So it's in layer 3. Then it gives off the mental branch here going into the to the chin and inferior labial as well. So these risks are really this facial artery. As we can see, it's deep there in that lower third. However, it's a very large caliber, and we need to adjust our depth of injection in order to stay away from the vasculature here. And we see that as this facial artery ascends, it's at its most superficial in the lateral alar base. This is where the facial artery will be at its most superficial. But in the lower face itself, it will be deep. So here we have our recommendations in terms of Where are the risks? Well, we've discussed those variations in layers. So in the chin there, we have risks in multiple layers. So we have risks that are more superficial, for example, branches of the mental artery that run, or the inferior labial artery that run along the labial mental crease, because the labial mental crease has no fat, it's just muscle and skin. And we have then risks that are deep as well from the mandibular foramen. So the risks are really multi-layered in that upper area of the chin. However, in the lower area of the chin here, we have our risks that are more superficial, as we've seen, because of this ascending mental artery, which starts deep and then becomes superficial. So really, vascular risks in the chin itself are multi-layered. So we will adjust our injection depth based on these anatomical structures. So our recommendation is, for the gonial angle, you can inject deep in that intramuscular injection, which will be into the masseter muscle as you touch the bone, or you can fan your product superficially along the gonial angle in order to enhance the jawline. Similar in the jawline itself, to create a straight mandibular line, we can use our layer 2 in order to enhance this, as we will be away from these anatomical risks. And also similar to the labial mental crease and the oral commissures. However, in the chin, we can be either deep with a needle, or if we're going to be superficial there, a cannula will probably give us a safer and more predictable outcome in that area. So now let's move on to aging and how the aging process will affect these 5 or 8 different layers that we have in this region, and how these changes is really what brings patients to our practice, because it's these changes that will create folds or deep lines and redistribution of volume that brings patients to our practices. So one of the things that we see here is we're going to see a combination of atrophy in the deep compartments and hypertrophy and atrophy within the superficial compartments in this area. And this really leads to those symptoms that patients complain of and why they come to see us. So we're going to explore these changes, both in the deep static compartments as well as in the superficial mobile dynamic compartments as they occur. And we have these beautiful illustrations from Val Ambrose from last year. These were taken from photographs, multiple photographs of these individuals throughout their course of, I think, around 50 years. And we begin to see anteriorly those changes that occur in the lower third. So we see that deepening of the nasolabial fold, the oral commissures, and the formation of the marionette fold also. And we begin to see that elongation of the upper lip and that inverse proportions where we see a ratio of almost 1-to-1 from the subnasally to the inferior border of the chin. And if we start to explore these changes from an oblique perspective, we begin to see the deepening of the nasolabials and also of the oral commissures and the marionettes, but also the mental crease. But we also see another thing occur here, which is that the jowl, which is this superficial fat compartment that is just lateral to the mandibular ligament, becomes larger as we age. So this is one of the things that occurs throughout the aging process. And from a lateral perspective here, we're able to view this with more detail. And we can see here how this redistribution of volume with the hypertrophy of the jowl and loss of volume in the deep static compartments leads to the disruption of that straight mandibular line from the gonial angle to the pagonium. The jowl will disrupt it. So this is really one of the reasons why patients come to see us. So it's important that we're familiar with how the aging process will affect this area. Now, do we age differently, male patients and female patients? Well, we do. We male patients, we have a more linear aging. So we age at a slower pace, steady but slow, whereas our female counterparts will have a very slow aging process. And then as we hit menopause, then you see a slight decline there, and you see really a speeding up of the aging process occur within this time period. So we both will age. However, our female counterparts, they age at a slower pace until they reach menopause, and we age at a steadier pace as we grow older. And if we explore these changes from deep to superficial, we will see the following. So first here in the bony platform here, we will see that the chin will lose its anterior projection, the mandible will lose its vertical height, and also the height within the gonial angle will be affected with the aging process. But if we look at this, if we were able to look at this image anteriorly, we will see that from the bony platform, the bigonial width here does not change. So it's really only changes that occur within the soft tissues. And this is a beautiful illustration here from Dr. Trevidick and E2E on how the aging process will affect the mandible. And we can see there these changes, loss of vertical height and angulation there on the gonial angle, and loss of anterior projection there within the chin itself. And also that shortening of the chin within that anterior part. But there's also variations in volume here. And the deep fat is subject to atrophy, but whereas the superficial fat is subject to either selective hypertrophy or atrophy. And here we see atrophy of fat in the chin, but then we see in between these two fixed structures, which is the mandibular ligament and then the premesenteric ligament, both of them fixed structures. So, and then in the middle there, we have the jowl fat. Now, these are two fixed structures there, the mandibular ligament and the premesenteric ligament. They're both true ligaments, so that means they're also cutaneous ligaments, so they have a cutaneous and a bony attachment. So think of them as two palm trees there, so two fixed palm trees there. And in the middle there, you have the jowl. So the jowl is an area of fat that's it's like a hammock. But then imagine that as we grow older, the weight within that hammock becomes larger and larger. And it's within those two fixed structures. So then it has only one way to go, which is down. And this is really what happens there with the aging process. That jowl superficial fat becomes larger, and it's sitting in between those two palm trees. There are fixed structures. So it goes down. So it has only one way to go, and that is down as we age. So that's what happens throughout the aging process. So we have areas of superficial fat that will atrophy, for example, the superficial fat in the chin that is responsible for its contour, and also the superficial fat along the jawline laterally, the preauricular region. But we have the jowl fat that will become larger. So it becomes hypertrophic. So we're beginning to understand, hopefully, a little bit more of these changes that occur throughout our lives and that occur in the deep compartments. So with the bone losing some projection, losing some of its vertical height, but also the deep fat there atrophying. But then above in the superficial dynamic layers, we see a combination. We see atrophy in the chin, superficial fat, hypertrophy in the jawline with the jowl becoming larger, and atrophy more laterally along the jawline in the preauricular superficial fat. So really what is happening here with the aging process here is a redistribution of volume that occurs because of these changes in both the deep static compartments and in the superficial, mobile, more dynamic compartments. So it's very important that we take these into consideration when assessing our patients, because we are not dealing with changes just within one plane. We're dealing with changes across multiple planes here. And in order for us to achieve a balanced outcome and to give our patients natural results and more effective use of product, it's important that we address the deeper changes as well as the more superficial ones as they occur. Now, in what proportion do these changes occur? Well, if we take into consideration these changes throughout the aging process, from relative to this mass, deep and superficial, so relative to our layer 3 to this mass or the muscle, deep and superficial, 47% of these changes will be within the deeper static planes, and 53% of these changes will be within the superficial dynamic compartments. So it is very important for us to address both of these changes as we treat the aging process, and hopefully this illustration of the aging process and the anatomy will help justify our volume restoration and our strategy behind restoring volume, not just in the deep compartments, but also in the more superficial compartments as well. So really to summarize here on how this aging process occurs. So first, remember the deep structures here are static, and they provide structural support there to the chin and the jawline. And the superficial compartments, so anything above this mass here, will be mobile. And also here is where we really see the combination of atrophy and hypertrophy of these tissues. And that jowl that becomes larger is really what disrupts the mandibular line as we age. And also this, the aging process in summary is the result of a redistribution of volume. Volume loss and volume gain is what is occurring. And this is occurring in the deep compartments, but also in the superficial compartments as we age. So for us to achieve a balanced outcome, it's important that we address both the deeper changes as well as the superficial changes. And as well, if we're thinking of maximizing outcomes, really, so we have a reason now to layer our treatments, so to address deeper static changes as well as superficial, more dynamic changes. But also, we're familiar now with the concepts of layers within the chin, 5 layers, within the gonial angle, 8 layers. And if we really want to maximize the expression of volume here, we need to think of how to achieve the most superficial volume. And we need to think about the number of layers and think, okay, well, if I have 5 layers here and I'm injecting deep here in layer 5, I have 4 layers to push up. Whereas if I have 8 layers and I'm injecting deep down here, well, I have these 8 layers that I have to push up. So it's not a very economical way of managing the aging process. So this is another reason really why we suggest that you think about the anatomy and also think about the aging process. And this is all peer-reviewed information. And then based on that, use your knowledge of rheology and choose the products that will adapt the best in these layers and that will give your patient a more balanced outcome. So now let's move on to our assessment and also to gender. And this is something very important now, as I pointed out in the introduction, and it's because these treatments are more and more popular. So now, because of the surge of social media and how we're viewing these treatments, we have patients coming to our practices specifically asking for a straight and uninterrupted mandibular line, or you might have male patients actually asking you for masculinization treatment to enhance their male features. So these treatments are very popular, but it's important that we are familiar with the differences in gender and also some of the differences in ethnicity as well, because they will affect the aging process as well. And here we have a few magazine covers here, and with male and females, and also with different genders and ethnicities. And we see a couple of things in common. And one of the things here that we see is that a straight, uninterrupted mandibular line, so from the gonial angle here to the pagonium, is a sign of youthfulness and beauty. And this is why even in someone like Oprah Winfrey, who is in her 60s, whether it is because of Photoshop or plastic surgery or non-surgical treatments, she has a straight mandibular line. And it's similar both with our male and our female patients. But there are some differences here, and we were going to explore these with more details in the coming slides. Now, we begin with the chin. The male chin here is broader and flatter, and this is because the width of the chin is different in our male patients, whereas the female chin is slightly more narrow. It has more subtle angles and not sharp angles like in the male chin, and it's slightly more round in its shape. If we look at the actual width here of the female versus the male chin, well, we have two different landmarks here to take into consideration. First, for our female patients, the width of the female chin corresponds to the intercanthal width. So corresponds to the distance between both eyes, and which also coincidentally corresponds to the width of the female nose. This is if your patient has not had a rhinoplasty, and also corresponds to, if you ask your patient to pout, it corresponds where they will have most of the volume of their lips. And if we look at the chin width here, it also corresponds to that same intercanthal width. So very important to keep this intercanthal width into consideration when assessing the female chin width. But if you think about variations in ethnicity, and we look at the differences in ethnicity, most of the differences in ethnicity we will see are within the upper third in the forehead and also within the intercanthal width. So if you have a patient, for example, from African descent, or even a patient from Asia, they tend to have a wider intercanthal width. So therefore, you might find that the chin, even the female chin, will be slightly wider, because remember that width will correspond to the intercanthal width itself. Whereas the male lower face here is slightly different. We see a couple of differences there in the chin. So the chin is broader and wider because the width of the male chin corresponds to the width of the oral commissures. And also, if we look at the three widths here that we usually assess from an anterior perspective, which are the bizygomatic width here, the bitemporal width, and the bigonial width, in our female patients, the bigonial width will always, the bizygomatic width, will always be the most dominant laterally projected one. And as our female patients grow older, because of this redistribution of volume that occurs within the soft tissue, we see the bigonial width becoming greater in our female patients. Now, for our male patients here, if we look at the bizygomatic width and the bigonial width, we can see that the bizygomatic width and the bigonial width are very similar. You can almost draw a straight line here from the lateral projection of the zygoma to the gonial angle. So this is why the male lower face is slightly more square, whereas the female lower face becomes more square, more bottom heavy as we age, because of that redistribution of volume that occurs throughout the aging process. But from a profile here, we have a different perspective here. From a profile, here we have the Frankfurt plane here from the upper alar in a horizontal line, crossing with a vertical plane from the nasion here to the pagonium. And we know that the chin should be within 2 millimeters of that line. Now, the male chin can actually afford to be slightly more projected to that line, whereas our female patients here, we expect the chin to be within 1 to 2 millimeters. And if that chin is behind that line, it will be what we call a retrognathia. There are different grades here, depending on how far back the chin is. And these can range between 1 to 2 centimeters. And traditionally, anything that was over 2 centimeters was considered to be a surgical candidate. Whereas now, with these non-surgical implants, we are able to treat these changes with our injectable implants. Now, there's something else that we should always take into consideration when assessing the chin, And this is more relevant when we're doing perioral treatments, so whether it's perioral enhancement or lip enhancement. But it's important that we're familiar with it because we have different soft tissue profiles. Whereas the class 1 is where the mandible is meeting correctly here. So we see that the projection of the chin and the pagonium, the point of maximum projection of the chin, is within 2 millimeters of that central line there from the nasion to the pagonium. But we have here a class 2, which is a retrognathia there, as you can see, and also a class 3, which would be a prognatic patient. So these are just some of the variations that might present to your practices that you have to be aware of for lower face enhancement, but also for perioral enhancement and rejuvenation. Now, the other thing here is the angles of the gonial angle. And these are different here because both our male and our female patients, remember, they have very well-defined gonial angles and a straight, uninterrupted mandibular line. But these are different in terms of the angle. So you see here that the male gonial angle is around 120 degrees, whereas the female gonial angle is more obtuse and it's around 130 degrees. But this is very important for us when we're doing a gonial angle enhancement. But remember, the other thing that is very important is that in our female patients, we don't want to increase the bigonial width because we want the bizygomatic width to be the most dominant one from an anterior view. So very important that for our male patients, we keep this these sharp angles here of around 120 degrees, but we are able to inject laterally here in order to increase the bigonial width. But with our female patients, we have to enhance these angles to around 130 degrees, but we have to also preserve their female features. So we have to focus on the posterior border and on the inferior border in order for us not to increase the bigonial width when we're doing a treatment. And we're going to see a couple of examples of doing this in our patients. So really, these are some of the changes and the differences in terms of the assessment from our patients. Differences in gender, briefly touched on some of the differences in ethnicity, but remember, these will be mostly in terms of the width of the chin and also in terms of how the facial shape will age. Our female patients throughout the aging process tend to become more heavier in the lower face region as we see that redistribution of volume occur. So now we're going to move on to some video demonstrations of treatments. But before we do that, I will discuss and share with you what my rationale behind product selection is. So in the lower face, remember, we have our deep static compartments. So we will see the aging process affect these when the mandible will lose some of its anterior projection, the pagonium, that deep fat will atrophy. And also the superficial fat will atrophy as we age. And it is really the superficial fat that's responsible for the contour of the chin. So the result of this is we begin to see some of those changes in along the chin. We see the formation of oral commissures, the marionette falls, the labiomental crease, but we also begin to see that very dynamic discord that occurs because of that loss of superficial fat and deep volume as well. So we begin to see that mentalis muscle and its orange peel aspect. And we also see how the DAOs will pull the corners of the mouth down. So this is why when I treat the lower face and the chin, and I want to maximize my outcome, I will treat both of these layers. So here I'm treating the changes that occur within the deep layers with a deep supraperiosteal injection of ultra deep. But then I'm also addressing those superficial changes with RHA4 in that subcutaneous plane in order to restore that superficial fat that I know is responsible for the contour of the chin. So in treating both the deep changes and the superficial one, we're able to actually modulate the activity of that mentalis muscle in the DAO and address that dynamic discord that occurs throughout the aging process. But then the other thing here that we need to take into consideration is the differences between the forces that we see in these deep static compartments, like on the bone and the deep fat, versus the differences of forces that we see within the superficial planes, which is anything above the muscle. And these are very different. We know that in the deep planes here, our injectable implant, our hyaluronic acid, will only be subject to compression and a little bit of stretch. So what does this mean? Well, essentially any dermal filler, any traditionally cross-linked dermal filler will be able to suit this area. But interestingly, the more superficial we go, so as soon as we go above the muscle, or if you're going intradermally, we have more pressures being applied to our dermal fillers. So we have higher forces being applied to these fillers that go beyond just stretch and compression. We begin to see shear and torsion being applied to the gel. So it's able that our volumizer, whichever volumizer we're using within this superficial planes, these dynamic planes, in order to achieve natural outcomes, it's able to be resilient when it comes to these forces applied to it, and not just able to endure them, because we see repeated constraints in these planes, and a rigid volumizer is not going to adapt well to these forces within the superficial dynamic compartments. So this is when really RHA and its unique characteristics come into play here when we're talking about dynamic forces being applied to them. And this is really something that is achieved by this unique manufacturing process, which is called the preserved network technology. So this patented process will place the HA in a sterile pouch, and it's going to very gently mix and heat under very low temperatures for a long period of time, DHA. And this is in order for it to not to traumatize the molecule of hyaluronic acid, and also to require the least possible amount of chemical modification. Because we know that the more or the higher the degree of chemical modification, the more rigid a gel is. And this is why we take this into account when we are treating these layers. And, you know, traditionally cross-linked products that you have in the market have a degree of chemical modification ranging from around 6% to 10%. Whereas RHA here, we see the range of chemical modification between 2 and 4%. And this is important here because that natural molecule of hyaluronic acid that you see on your left is a great natural dynamic volumizer because of its long chains and an entangled network and these natural bonds in between them. So it's an entangled network there that is able to adapt to movement, and it's able to adapt to these repeated constraints of facial movements. But traditional cross-linked processes will heat the molecule to the point that it breaks it down. So therefore, it requires more BDDE, more chemical modification in order to convert this into a gel. So remember, the more BDDE, the more rigid a gel will be. And here we have RHA. And RHA, because of this gentle, unique manufacturing process, is able to preserve as much as possible of the hyaluronic acid molecule without sacrificing on the longevity and requiring the least possible amount of chemical modification. So this is very important when it comes to these dynamic areas like in the chin or in the lower face, anywhere in the superficial planes, as we want something that is able to adapt to the multiple constraints of facial movements and not just a rigid gel here. And this simple illustration here, I think, is managing to just highlight this. So whatever plane whatever product we place in these superficial compartments has to be able to accompany facial movement. Whereas whatever gel we place here in the deep compartments there only has to withstand some compression. So it just has to be rigid. And this really shows you why we need sort of two different properties, really, if you're going to address purely the deep layers or the superficial layers. We need different properties in our volumizers so that we can achieve more balanced outcomes. And the way that we assess the performance of these gels is we have to move away from static measurements and take into consideration measurements from material sciences that are more relevant to the multiple and repeated constraints that we see in the human face. So in the human face, we see more than a single constraint. So this is why we measure stretch and strength. So the stretch will be the ability of the gel to adapt to movement and recover, whereas the strength of the gel here, it's almost a dynamic G prime here. It's testing the ability of the gel to maintain its physical integrity over a wide range of constraints. And this is very important for us because a G prime is only testing across a single domain, whereas the human face has multiple constraints and multiple movements. So it's important that our gel is able to adapt to the multiple constraints of facial movement. And if we look at the stretch and the strength here of RHA4 versus some of the most common volumizers that you see in the market, we see a couple of things here. And you can see that the strength of the gel is significantly higher, but also it's able to preserve a very good stretchability. So this means that the gel will be able to adapt to the mechanical stress that it's being placed in those dynamic compartments. So it will be strong to volumize, but it will be able to adapt to facial constraints. And remember, you don't have to be rigid to be strong. So this is why RHA4 is very well suited for these dynamic areas and for these compartments. So we use the combination here of Ultra Deep, which is a traditionally cross-linked product. So it's our deep super periosteal volumizer, and 25 milligrams per mil of hyaluronic acid, highly cross-linked, 10%. And the result of this is a very cohesive, high G prime traditional stiff gel that will be able to mimic those properties of the bone in those static compartments. But then you have RHA4, which is 23 milligrams per mil of hyaluronic acid, but only 4% modified. So this is a gel that has a very high strength, as you've seen earlier, but also has a very good stretch. And this is why this is my favorite gel to use for volumizing extended areas and these very dynamic planes that we have in the lower third. And this is my rationale behind really using RHA4 in these large surface areas. So here we have a little summary here of the multi-layering techniques to create more projection and lift capacity. Ultra Deep, or traditionally cross-linked product, will be able to achieve that. But then we're going to also address the superficial changes that occur throughout the aging process with our strong but yet malleable volumizer in these layers. And we'll be able to address both the deep static as well as the superficial more dynamic changes. So now let's move on to the practical part of things here, as I've been talking for 50 minutes now, so I'm sure you want to see a little bit of the fun stuff here and before we can have an interaction. So this is a gentleman I treated in Warsaw a couple of years ago, and he was telling me that he's in his mid-40s, and he had very well-defined lower face features. And as he's grown older, he's noticed that lack of projection in his chin, that labial mental crease, and jowling. So I begin by volumizing the deeper planes here. So I'm using Ultra Deep here. So this is a deep injection onto the gonial angle with Ultra Deep. Remember that because of the 8 layers that we have here, and the fact that there is the masseter muscle is attached to the bone here. This is an intramuscular injection. So I always use a small bolus. And this is an injection that I will only do with my female patients because I don't want to increase the bigonial width here of my female patients. So I'm doing a small bolus there of 0.2 for our gentleman. And then I'll continue here with the deep planes in this area. And my next injection here will be deep in the pre-gel sulcus, and this will be able to restore that loss of vertical height there of the mandible, and it will begin to soften that marionette fold in that pre-gel sulcus. And again, this is a deep injection, and it's also something that I do not do in my female patients because I don't want to increase the width of the female chin. So this is why it's a treatment that is suitable for my male patients. So I'm still with Ultra Deep doing a deep injection there into the pre-gel sulcus, and this deep injection is around just 0.1. So this is just a very, very short injection that I'm going to do of just 0.1 there. So now we move on to the chin. Male chin is broader, so I usually treat it in 2 different boluses instead of a single bolus. But in this case, I'm doing 3 boluses there of 0.2 to 0.1. So I begin there from lateral, and I just start to move more medially there as I continue. And I'm doing actually just 0.1 in each one. What I do now is I just split my bolus and my volume into 2 injections instead of just spreading it along 3 injection points. So these are the deep injections with Ultra Deep. So now we've used a traditional cross-link filler, a stiff, rigid volumizer for these deep static compartments. But now also we have these changes that occur within the superficial plane. So all that atrophied superficial fat, we're going to restore that by targeting the superficial plane. So we're going to use RHA4. And here I'm using a 25 gauge 38 millimeter cannula. And as you can see, I bent the cannula a little bit. And this was just so that my cannula is not in contact with the ear and with the neck as I inject and place my product. But you can see how superficial I am, because here, remember, you're either deep on the bone there, or you are superficial as we have the parotid gland there in the way. So here I am injecting deep. And I'm going to be fanning my product here along the inferior border, but then I'm going to continue to fan the whole product all along laterally along the gonial angle going towards the posterior border. The reason for this, remember, is because here with my male patients, I want to increase the bigonial width. So I want to enhance these features. And this is why I'm doing that. But this is how superficial I am. And I'm going to inject 0.8 of my RHA4 around that area there. And I'm going to continue to fan that along that area and move towards the posterior border there as well. So 0.8, and you can see how easy it is to mold my RHA4. But also, I'm going to enhance that chin line and the mandibular line in the chin, in the marionette. So this is what I'm going to do, for all of my friends from Australia that just have 1.2 cc of RHA4. So this is what I'm doing with the extra volume. I'm multi-layering it, and I'm using that little bit of extra volume in order to treat the chin line and the marionette and the mental crease after doing my deep injections. So it really shows how a little bit of this volumizer, I think, can go a very, very long way here just by placing it superficially. Because remember that we have these changes that occur, and the superficial fat here has atrophied as we age. And this is why I have this rationale of targeting these different layers with volumizers that will be able to adapt to those constraints that we see in those areas. So here's our patient immediately after. So with a very modest amount of volume, really, 3 syringes in total of product in the lower third. So 1 syringe of Ultra Deep and 2 syringes of RHA4. And we begin to see there from a profile how we're really creating a straight, uninterrupted mandibular line. And we can appreciate those enhanced angles there with the combination of using a deep volumizer as well as a superficial volumizer. So this is just some of the changes that we can create really by targeting different planes, but also by maximizing the efficiency of using these products and targeting those superficial layers. So now let's apply these concepts for female patients. So here, remember those changes that we discussed with our female patients and a couple of cases as well. So we have, this is a 39-year-old Holly who I treated in June. And Holly, as you can see, has a retrognatic chin there. So if we look at her chin and we look at that nasion here, so that chin is almost 3 centimeters from that vertical line there. And also if we look at her mid-face, very flat anterior mid-face as well. So we're going to, I treated her mid-face with multilayering with RHA4, but we're going to focus on the lower face treatment and how I was able to project that chin more than 3 centimeters with a very modest volume of product. So first we begin with our deep injection. So I'm doing 2 deep injections here with ultra deep, and I'm very, very slow injector. So I'm injecting 0.2 on the pagonium, and then I will inject 0.2 on the gnathian. So, and that's as much volume as I will inject in this deep plane, staying within the midline, as remember the width of the female chin corresponds to the intercanthal width. And I've used only 0.4 of my ultra deep here. But now we're going to continue to project that chin forward and down with just targeting the superficial plane with RHA4. So this is a 38 millimeter 25 gauge cannula, and I'm staying within the natural width of the chin, so corresponding to the alar base or the intercanthal width there. And I'm going to just fan my product there into that superficial fat. If I was treating an older patient, I would just do my entry point a little bit more laterally to have access to the oral commissures and to the marionette line, but we'll inject it within this same plane. And on average, I tend to use 1 syringe, depending on how much volume I need to, or projection I want to achieve, but I use no more than 1 syringe in this superficial plane. And you can see how superficial I am there. And I will do another entry point here on the opposite side. So 0.4 of ultra deep, deep down on the bone, and 1.2 of RHA4, we're able to project that chin over 3 centimeters there, as you can see, and achieve a very natural outcome with something that is a very modest amount of volume there. Her cheeks were also treated with multi-layering with RHA4 with 1 syringe. So this is really one of the benefits of being able to target those deep static changes as well as the more superficial dynamic ones, but also being able to create more volume here in these dynamic compartments and maximizing our surface volume coefficient. How am I going to get the most projection from my products? Is it going to be injecting deep down on layer 5 or superficially on layer 2? So that's what I'm taking into consideration when volumizing. And here we see the volumetrics. Objective data does not lie, and we were able to create almost these 3 centimeters of projection there. So we see in the blue there that chin is in line with that nasion there in that medial plane, and how by just treating the anterior midface also we're able to create a reduction in volume there in the lower face as well. And now we're just going to explore another case of jawline treatment in a female patient with chin and jawline treatment. So here we have another class 2 chin, which we will approach in a very similar way. And we will do this here. And remember, there are 3 points that we can use to inject the chin. The top black circle there is on the pagonium. So that's the point of maximum anterior projection of the chin. So I will use that if I want to bring the chin forward. And then just under it, we see the gnathian. And this gnathian will be able to give us anterior projection, but also to elongate the chin. And just below it, in the inferior border here of the mandible, we have the menton. And the menton we use if you just want to elongate and not create any anterior projection. So those are the 3 deep areas that we can use in order to create more anterior projection. And also remember, depth here is important because of, in particular, that ascending mental artery. So we have here the depth of the artery that goes from deep to being superficial. So another reason why I adjust my my injection depth and also my product of use when doing this. So I'll begin with my deep supraperiosteal injections. So I'm targeting the pagonium first, and this is with ultra deep, and this will be a 0.2 volume also. So you can see my deep injections are very low volumes as well. And after doing this, I'm going to treat the gnathian, which will allow me to give some anterior projection also, but to elongate that lower third so that it's more imbalanced, and it's a 1/3 to 2/3 from the subnasale to the menton. And another deep injection there, supraperiosteal into the gnathian. But we continue here, and similar to our previous patient, we're going to use most of our volume here superficially, and we're going to use the superficial fat, which is responsible for the contour of the female chin. So we're going to use this, and we'll start with the labiomental crease, and then we will move down, and we will stay very superficial. So I'll create a tiny bit of volume there, and I'm staying within that natural width of the female chin, but I'm very superficial, as you can see, staying within that natural width, allowing me to continue to bring it down and also to bring the chin forward. And then I will do exactly the same thing from the opposite side. And just remember, this was using half a syringe, so I'll use half on each side. And remember, it's that superficial fat that's responsible for the contour of the chin, and that it's also responsible, that absence of that superficial fat, for that dynamic discord and those changes that we see throughout the aging process in the lower third. So there we've just treated one side, and we're able to see that chin begin to come forward. We'll look at the objective data in a second. But for the jawline here, for my female patients, I don't want to increase the bigonial width. So I'm going to focus on the inferior border of the mandible and also the posterior border. And I'm using very small amounts of product. I'm using RHA4, same 25 gauge, 38 millimeter cannula. And I'm focusing here on the inferior border, and then I'll move towards the posterior border, as I do not want to increase the bigonial width for these patients. I just want to enhance the gonial angle. And I always leave the product a little bit bumpy. That was just 0.3. And it's only to show how easy it is to mold the product. And you can see how easy it is to mold it there by placing product deep, by placing product superficially in that subcutaneous plane, which is something that really you wouldn't be able to do with those traditionally cross-linked volumizers. And this is her immediately after. So we begin to see that chin and that definition of the gonial angle that we carried out with very modest amounts of product. So it was less than 2 syringes of RHA4 and less than 1 syringe of ultra deep. And here we have the overlay there of the before and after. And when we measure it, so here we have objective data there, how much volume, almost 3 centimeters of volume was able to create there. And here we see something very interesting, which is in blue, that increase in volume. So by adding volume into the chin itself, and then laterally along the gonial angle, we see here in yellow and orange a reduction of volume along where the jowl is. And the reason for this is really because what we see there, by adding volume away from the jowl, we're able to define the jawline here and create more volume anteriorly and posteriorly. So just to summarize, really 3 things that we like to take into consideration: the anatomy and the aging process. Then based on that, we will choose a technique that will allow us to deliver a safer and more effective treatment for our patient. And then we will take into consideration the rheology. What are the biomechanical properties of these layers? What stresses and constraints will be applied to my hyaluronic acid? And I will choose the right product there for the right depth in order to achieve a natural outcome. And this is really where the multi-layering technique really comes in place, because we are taking into consideration here the different properties, addressing the aging process as it occurs, deep and then superficial. So we use ultra deep, which is our static stiff volumizer for the deep supraperiosteal plane. But then we will also use RHA4, which is our strong but yet stretchable volumizer there, in order to respect the dynamic aspect of the face, and those especially in those highly dynamic areas like in the chin. And these are our multi-layering techniques, are 2 volumizers, so 2 volumizers for 1 solution: structural deep support, ultra deep, and dynamic volumizer and contouring with RHA4. And with that, I've been talking for 68 minutes now, almost 69 minutes. So I'll stop sharing my screen, and hopefully we can have a little bit of an interaction here with our friends, Jackie.
Hi, Dr. Raul. Thank you. I want to congratulate you. I think you delivered one of the most comprehensive and most interesting lectures I've ever heard about the lower face. And I think sometimes we are so focused on the mid face, we hardly give attention. And I think that's also the reason why tonight we have a record high, almost 500 participants. So thank you, doctors who are online and spending your evening with us this evening. So with that, Dr. Raul, I'm going to have some interaction with you, and then we have quite a number of questions coming in from our participants tonight. Doctors, you still can put in your questions if you are processing all the information right now. You can still feel free to key in your questions into the live chat or the Q&A section, and then we will take your questions. All right, Dr. Raul, let's go to the first one. Dr. Raul, can you explain once again about the gonial angle, how it interacts with the masseter muscle and the parotid gland? So I think this doctor is asking about the relationship between these 3 structures, how it interacts with each other.
So remember, we're viewing the anatomy in layers, and in layers means that we have to familiarize ourselves with variations of layers across the whole face. And the gonial angle is one of these areas of variation. And the reason for this is because you have bone, and then on top of the bone, you have the masseter muscle that's attached to the bone. And then above the masseter muscle, you have the inferior part of the parotid gland. And then you have the platysma, and then you will have the superficial fat, and then the skin. So what it means is we have 8 layers and a different arrangement, because you have the parotid gland in the middle, and also you have the masseter muscle there that's attached to the bone. So usually you will have, like in the chin, you will have bone, and then you will have a deep fat. But here we have bone and muscle, and then you have the parotid gland there in the middle.
Right. This is a question more talking about the marinette area, sometimes we use cannula to separate the tissue from the mandibular ligaments while depositing filler. Does that help in reducing marinette lines?
So the mandibular ligament, remember, it's an ossicutaneous ligament, so it's a very strong ligament with a bony attachment inferiorly. So I think that subcision is only helpful for you to create a plane for your RHA4 or RHA3 if you wanted to use RHA3. It won't really do anything much because you're not able to detach that true ossicutaneous ligament, but you are able to, with your cannula, do a subcision to separate the skin from the muscle, from the DAO, and then create a plane of your RHA4. So that, yes, definitely you're able to do that because that superficial fat there in the marinette will atrophy, and then we'll end up with skin that's attached to the muscle.
Dr. Raul, when you look at the appearance of the jowl, it looks like in the inferior portion near where the marinettes are, there's an atrophy of the fat. And then in the superior aspect, there's atrophy. And in the inferior, there is where the jowls are, there is a hypertrophy of the fat. So how would you treat the marinettes? In that case, if you can't really do the subcision, how would you treat the marinettes, and which product will be your product of choice to put in this area?
And why can you not do subcision? Sorry?
Going to the question just now about the subcision. So you said that when you inject, you're really just separating the skin, that muscle.
Yeah.
So, yeah, and then we'll go on to treat the marinettes. So if we go on to treat the marinettes, how would you treat it, and what product of choice would you choose?
So I treat it as we've just discussed with a cannula, and similar to how I was enhancing the chin. And with a cannula, I'll do subcision and then place product to restore that superficial fat of the chin that is absent, and it's creating a sharp transition between the jowl and the chin itself, which is what the marinette fold is. So you have there the mandibular ligament separating the chin from the jawline, and just lateral to the mandibular ligament, you have that area of jowling, which is of heaviness. So the aim of the treatment there is to create a smoother transition between the jowl and the chin.
And in this area, you will still use RHA4? Would that be a product of choice?
Yeah, absolutely.
Okay. Good.
You can opt to use RHA3, if you're not comfortable injecting superficially, which is something I did when I was becoming a little bit more comfortable with superficial placement. But in my hands and in my practice, you've seen in these videos, definitely RHA4.
Okay, perfect. Dr. Raul, how do you inject on the superficial layer of the chin when there are, superficial arteries that comes from the ascending mentalis arteries?
From the ascending mental artery. So the way to do that is by staying superficial, so staying in that subcutaneous plane, and preferably if you can using a cannula, because the arteries, those branches of the ascending mental artery will be within your layer 3, so they'll be within the muscle. So cannula and staying in that subcutaneous plane will help you achieve a safer outcome and more predictable one.
And do you have a cannula size that you would recommend to use with, or 30, 27? Which would be the one you use most?
No, so my cannulas, I would suggest that you use something that's 25 gauge or larger in order to minimize any potential risks. And this is because anything that's 27 gauge or thinner is as sharp as a needle. So if the reason why you're using a cannula is because you want to minimize the chance of encountering a labial vessel or any blood vessel, then it's wiser to use the larger cannula, so 25 or 22 gauge.
So a 25 gauge cannula with RHA4 to do superficial injection of the chin. Next question, Dr. Raul. Thank you for your great webinar presentation. Can I check, how do we plan our male chin filler injections with respect to, again, this question about the ascending mental arteries, as the male chin should be projected broadly rather than sharply?
Yeah, and shout out to my good friend, Dr. Asek Wong.
It is. Yes, it is a question from Dr. Wong. Yeah.
So the way we do it is you spread your volume. So when you're injecting deep, you spread your volume. Usually I do it into 2 boluses, although the patient I treated there, I did 3 boluses, but I tend to do it 2 boluses. So that means that we're respecting that width of the male chin. But then, similar to with my female patients, I was staying within that intercanthal width, so within that natural width of the female chin. That's where I was enhancing and adding volume. With a male patient, that will be in line with the oral commissure, so it will be slightly broader, both for the deep injections and for the superficial ones.
Okay. Then the next question, do you inject RHA4 on the gonial angle for a female patient? And if you do, is it on the superficial or the deep layer?
So deep injections on the gonial angle, as I mentioned earlier, I don't do these with female patients because I don't want to increase the bigonial width. What I do is I actually, I will fan RHA4 superficially. And as you've seen me do it, I do it with a cannula in that subcutaneous plane, tending to stay within the inferior border and the posterior border, and avoiding increasing the bigonial width.
And Dr. Raul Chato, do you always treat the preauricular area as well when you're looking at the jawline?
If you're looking at enhancing the angles, then yes. And also if you're looking at the aging process, and this is really because remember that the aging process will atrophy that fat, and that causes that submalar hollowing here. And also it will cause that lack of definition there. So yes, most of the time, yes, to answer your question.
Okay, so most of the time you're always looking at as an area rather than in isolation. So always looking
absolutely.
at the jawline, the preauricular, and the chin projection, and then
absolutely, especially if I'm treating an Asian face, we really want to respect that facial shape, and it's important that we address that submalar area and that sort of posterior border of the jawline.
And very quickly, Dr. Raul, if you treat the preauricular area, it's also a superficial injection with RHA4 using cannula?
Yes, so it's layer 2.
Okay, perfect. Wow, we have quite a number of questions on Marinette. Do you treat the Marinette line directly, like injecting into the mandibular ligament?
So the Marinette line is treated by first of all, restoring the lack of bony projection, but then also restoring the absent superficial fat. So layer 5 and layer 2, and that's where you treat it.
Okay. So how do we avoid squaring the lower face too much? I think you've talked a little bit about this in a question before when you revolumize the lower anterior face. So I think you do not place a bolus into the gonial angle. You just treat the jawline as well as the preauricular fat pad. Am I right to say that?
Yes. So just don't increase the bigonial width in your female patients.
Yeah, especially for the Asian face. This is a comment. Thank you for one of the most comprehensive and well-taught lectures, as I mentioned at the beginning. Your second class 2 retronetic patient. Can you explain using the angles, lines, proportions again, how you decide to lengthen the chin vertically?
So you just have to take into consideration either whether you like to use Ricketts lines from the nose to the pagonium, or the Frankfurt and facial plane, from the nasion to the pagonium. The chin should be within around 2 millimeters from that line in profile. So that's what can guide you in terms of how much the chin should be projected.
Okay. I'm not sure, Dr. Rao, if I understand, but I'm sure you do. Do you put volumes in the hammock in order to straighten the jawline?
Well, that will defy the purpose of camouflaging. So if you have an area of heaviness, remember, we have to add volume away from it. So that's why when you saw me treat those patients, I was adding volume away from the gel. Because if you want to camouflage it, then we need to add volume away from the area of heaviness, which in this case, it's the hammock.
Yeah. So it's almost like there's a traffic jam there and we are trying to drive away. So you are sort of injecting posteriorly and inferiorly, not where the hammock is to exacerbate the problem. A nice comment here, Dr. Raul. Good evening. Very inspiring lecture. Thank you. I would like to ask you about the bigonial angle as in jawline. For most women in Asian type, we would like to have a subtle jawline but defined. Yet when aging occurs, I think we lose those lines. How would you recommend approaching, how would you use RHA and Ultra Deep to define the jawline? So I think Dr. Raul has explained this a couple of times. Dr. Raul, can you just quickly do a summary using these two products? How would you solve that problem?
Yeah, absolutely. So you have to first we have to assess the mid face. Remember, especially with the aging process, and in particular the anterior mid face for the aging patient, as you mentioned, because we tend to have a lot of heaviness in the lower third. So we will assess this first, and if needed, I would recommend that you start your treatment there, because any treatment, remember, will have a indirect impact on adjacent areas, and the mid face will have an indirect impact on the lower face. And then I will focus in staying away from the areas of heaviness, just to enhance the angles and to contour. So superficially, away from the areas of hypertrophy, with a cannula and with RHA4.
Perfect. The next question is about causing a bruise. Dr. Raul Chetto, very challenging. How do you avoid causing a bruise if you are injecting superficially?
Well, a cannula will help you avoid a bruise, although there is no foolproof way of avoiding a bruise, as you know, because remember that anywhere that you put a needle through, there's a chance and risk of a bruise. But yes, using a cannula will usually help you try and minimize that.
Okay. I like the next question from Vicky. The most difficult issue I have is when a client needs multi-layering for gelling but has limited budget. In that case, which layer would you treat first to give the greatest aesthetic effect? I think this is a little bit about the surface volume coefficient, Dr. Raul.
Yeah, but it's also about assessing your patient, because if you're, yes, you're right, Jackie, in saying that, if you treat layer 2, you'll have a greater overlying projection. However, it's very important that you assess your patient and assess the deeper losses as well as the superficial ones. But I would suggest that you fully treat one area. For example, whether it's the chin or whether it's the mid face, instead of undertreating it, in my experience, because I think that undertreating an area will leave an unhappy patient, and therefore that probably won't drive more business into your practice. So always, have an open conversation with your patient during their initial consultation and assessment. Develop a treatment plan, write it down, print it for them, get them to agree to it. And that way you're taking them on a journey, and they're aware of what this journey will be and each single step will be like. And then you have them engaged, and you engage them in their own treatment. So that's how I would approach it. But I wouldn't undertreat, really, because I don't think that will benefit anyone.
Okay. Okay, this is a comment. Sorry to clarify. Did you inject on the inferior border of the mandible to increase the vertical height?
No, we treated on the chin, we treated the pagonium and gnathian. And on our male patient, we treated the gonial angle, we treated the pregel sulcus, and we treated the pagonium.
Okay. This question, okay, doctor, when you create the jawline, do you combine Ultra Deep and RHA4? For example, if you inject a bolus with Ultra Deep in the angulus mandible. I think it's the mandible angle, and you combine with the RHA4. Where do you start to inject the RHA4? Is it the upper part of the mandible angle and then go to the jawline?
It really depends on the case, if I'm honest with you, because if you're treating the whole lower third, then I usually will start by injecting the chin first. If you're treating the aging process, I find that this gives you a much nicer outcome, because in those spaces, remember that the superficial fat here will be absent, and you will. By just bringing that chin forward, you'll be able to enhance that whole mandibular line. So I will always start with the chin, and then I'll move my way towards the jawline.
Right. Okay. Doctor, if you have a patient who does return with a disruption in their lymphatics due to incorrect placement or diffusion of the product, is there a way you can correct or improve this?
Well, it's a stubborn thing when you disrupt lymphatics. Well, you will have to dissolve the product that's been placed inside of the parotid and do lymphatic massage, basically.
Right. Okay. So, well, I think I have asked all the questions. Wow, this is the first time we have so many questions. I see good interaction with our doctors. Before we go for this evening, Dr. Raul, I will just ask you to very quickly give us a little bit of summary. I mean, there's so much content that's shared this evening. If I'm a doctor who has been injecting chin always deep, using a good volumizer, why do I actually essentially have to change to using the multi-layering technique, in your opinion?
So first of all is because one of the things that we've changed the most over the last decade is our understanding of the aging process and the anatomy. We're still finding new structures there in the face as early as 2019. So really, it's the more we learn about the anatomy and the aging process, and also the characteristics of these tissues and how they age, the more really that you are not able to justify doing single plane injections. So we have to do multiple plane injections, so multi-layered injections, but also we have to consider the different properties of these layers, especially the deep static compartments with the superficial dynamic or mobile compartments. And we really have to marry our anatomy with the rheology, and that's what we're proposing, really.
So, Doctor, if I can do a quick summary, the beauty of the multi-layering technique in the lower face, really, I think you mentioned just now, deep injection will give you the lift, and then superficial, the contour.
Well,
is that right?
I mean, that's it depends. It's semantics, really, because I don't think that dermal fillers lift. But yeah, I mean, you're able to contour in a balanced approach and in a much more natural approach. If you target the deep static and the superficial dynamic, that will help you revolumize and contour, definitely.
Right. Maybe we should change the word to projection, right? And then contour.
It's purely semantics, Jackie. It's not nothing. It's not neither right or wrong. It's just purely semantics. But when you're in a panel of plastic surgeons, then they'll say dermal fillers don't lift. Only surgery or threads and things like that lift.
I know there's a difficulty with the language. Okay, doctor, just very quickly, between the male and the female patient, what would you do differently?
First, male chin broader, female chin narrower. Male bigonial width broader, female it's bizygomatic width is greater. So just respect those proportions and think of that before you do a treatment.
Right. So any last words you want to share with our doctors who are online this evening from your lecture today?
Well, first of all, thank you so much. I just typed in, thank you everyone for joining me this evening. It's been amazing. The amount of engagement has been incredible. Always just think of the assessment of your patient also at the same time of the aging process, and then try and maximize your outcomes by doing that, really. So just take time with your assessment and your consultation, and I think you'll have happier patients, and they will definitely come back.
Yeah. The comments are still coming in. Many of them. Thank you, Dr. Rahul, for your very informative lecture. And I'm also going to end off. Always, I leave my doctors with the Tioxan approach. Know the anatomy, doctors. I think that's the least we can do in our practice. Have your technique. Choose the best technique you can to treat that problem. And lastly, select the best possible product you have that can help you to get the best outcome. So with that, I will pass the time to Krish to close us for this session. Thank you, doctors, for spending the time with us.
Hey, thanks, Jack. And thank you, Rahul. That's one of the most comprehensive lectures and demonstration with a lot of practical tips, as someone has said. And it's only befitting that we had about 500 people. And Jack, she does extract a pound of flesh with the questions, doesn't she? Nice one, a good dialogue. I think that's really what people want to get more clarity, be it someone who's already using Tioxan products as you set it up right at the beginning, Rahul, or someone who has not yet had the opportunity and is curious about the possibilities. So as I always say, please do reach out to our partner markets if it's in any part of Asia or in Singapore directly to Tioxan, or in Australia, New Zealand to our team. We thank you for your time, for your engagement, for your queries. Each of these motivates us to do better. And again, I want to give a big shout out to Rahul for pulling together one of the most, like I said, comprehensive presentations for us from a simple brief. So Rahul, can't thank you enough. Really big round of applause to you for all that discretionary effort you put in to simplify things for us. And it has to be acknowledged, some of the markets are in a lockdown. I hope they're using this, and we can probably sense that they're using this time productively. Please do stay safe, ladies and gentlemen. At Tioxan, you're just an email away from any information that you may need. Happy to help you out in any possible way we can, and we appreciate your partnership and your support. Have a good evening, everybody in Asia, and Rahul, have a great day ahead, and I wish you a wonderful holiday. I think you're taking off now, aren't you?
Not taking off, just staycation.
Okay, brilliant. All right, stay safe, enjoy your time, and have the digital break. Rahul, thanks again, and have a great day. Everybody, have a nice night.
Thank you, everybody. Thank you for your time and support. Thank you.